Okay, so good afternoon, everyone. My name is Dominic, and welcome to today's presentation on pre-labor rupture of membranes. We are doing this as part of a project we call the Maternity Service Agenda. We had the first presentation on postpartum hemorrhage with a very high attendance, with very good reviews from people. I'm sure today you also enjoyed this presentation, which is on pre-labor rupture of membranes, commonly known to most of us who are not gynecologists or obstetricians as preterm rupture of membranes. I'm sure we'll learn a couple of new things, just like terminology that is also put up here. So let's take and stay with Betty as she takes us through the presentation. You realize that when she starts the presentation, you'll be unable to unmute yourself. So kindly make use of the chat box so that you can put in your questions, just in case we may forget about them at the end of the presentation, so that in about 30 minutes, we can have a discussion around it. Thank you so much for joining us today. Help me to welcome Dr. Betty. Dr. Betty, your audience, please take over. Thank you.
Thank you very much, Dr. Katiba. I am Betty Gyogluu, Medical Officer with the OBGY department, presenting today's topic of pre-labor rupture of membranes with my specialist, Dr. Gildas Mbaba Mawara. So this shall be the outline of our presentation. And before we start, let's have this brief introduction. So PROM, which previously, and I mean, we all used to know it as premature rupture of membranes. And this occurs in approximately 12% in all pregnancies and about 8% in term pregnancies. And it is associated with 30 to 40% of preterm births, and it results in significant maternal and neonatal morbidity and mortality. Let's familiarize ourselves with certain definitions with respect to this presentation. So we have what we call pre-labor rupture of membranes, which is PROM, which is nothing less but the rupture of fetal membranes or chorioamniotic membranes before the onset of labor. Then we have PPROM, which is preterm pre-labor rupture of membranes, which refers to the rupture of membranes occurring before 37 weeks of gestation. We have the term PROM, which is the rupture of membranes after 37 weeks of gestation. And we have something we call the latency period, which is a time interval between the rupture of the premature rupture of the membranes to the onset of labor. This comes to play when it comes to the management of patients, where you realize that the period of latency is inversely proportional to the gestational age. They also have prolonged PROM, which is PROM that's 24 hours after the onset of labor. So let's talk a little bit about the structures that come to play when we talk about PROM. So we have the fetal membranes. So these fetal membranes are in 3 layers. And they are made up of an inner layer called the amnion, which is relatively very strong, a middle layer, which is collagen rich, and it also replenishes the amnion. And we have the outer layer, which is the chorion, relatively weak. This fetal membrane protects the fetus from infections, but also plays a role in cervical dilatation when it comes to labor. So this is just an illustration of these membranes. So we have the chorion, which is on the outer part, the amnion, and we have the amniotic fluid with the fetus in the middle. We also talk about the amniotic fluid. So as we saw initially, this is the amniotic fluid. So this amniotic fluid, in the first half of pregnancy, usually is produced by the placental surfaces, the fetal membranes, and umbilical cord and fetal skin. But as the pregnancy advances towards the second half, about a liter of amniotic fluid is from the urine. So you have the fetus producing at least a liter of urine a day and about 350 mils from the fetal lungs fluid. What are some of the functions of the amniotic fluid? So it protects the fetus from lung trauma. It helps in lung maturation, lung development. It also helps the fetal extremities and gross body. It provides a space for the fetal extremities and gross body movements. It cushions the umbilical cord and protects us from compressions, and also protects against infections. So when it comes to the etiology, what causes PROM, it is not entirely known, so it's idiopathic. However, there are certain risk factors that when a patient has or that can predispose this patient to having PROM. So we have infections, be it ascending infections from gonorrhea, from chlamydia, from vaginosis. We have women who smoke, and studies have shown that it increases their risk of PROM about 2 to 3 folds. Prior PROM, prior preterm delivery, cervical length less than 2.5, that's women with cervical incompetence, multiple gestation, bleeding in pregnancy, and then so if you the your chances of having PROM increases with the number of bleeding episodes you have during your pregnancy. We have polyhydramnios, we have invasive procedures such as amniocentesis, we have acquired or congenital connective tissue disorders such as Ehlers-Danlos syndrome. We have nutritional deficiencies such as vitamin C, which is very important in the production of collagen. Some studies also show zinc and copper as well play a very significant role. So let's talk a bit about the pathophysiology. So generally, as pregnancy advances, these membranes that we spoke about earlier begin to weaken as it prepares the body for labor and delivery. So there's a programmed cell death where there's activation of enzymes such as collagenase and mechanical forces that leads to this rupture of membranes. Now, when it comes to PROM, these processes are activated too early. So some of the risk factors we spoke about are implicated in this. So at the end of the day, you have an inflammatory response occurring that causes the release of prostaglandins, and these prostaglandins lead to cervical ripening and causes contractions to occur. And also we have the implication of certain enzymes called the matrix metalloproteinase enzymes that cause the degradation of collagen. And these factors combined leads to the rupture of these membranes. So let's talk about the diagnosis. How do these patients present to us? So these patients usually present with a history of gush of clear fluid or light yellowish fluid from the vagina, or they'll have a history of steady leaking. They tell you, oh, I've been seeing this leaking that comes and stops, comes and stops. And then they talk about their underpants being wet or their beddings being wet when they wake up. So usually this is how they present, but we should take a very good history to know the timing and onset of this leakage, the amount of fluid, like try to estimate the amount of fluid that is being lost, the color, and then if this this leakage or this gush of fluid was associated with pain or not, when which one occurred before the other, and whether or not there is some form of vaginal bleeding. Then we come to the physical examination. We should do a head-to-toe physical examination of these patients, starting from the vitals. Then we check the patient for pallor and all of that. And then we look at the abdomen, check your symphysiofundal height, check your presentation, check for tenderness of the uterus, check the tone, check for uterine contractions, check your fetal heart. Then we come to the sterile speculum examination. So we pass our sterile speculum and then see if we can see any fluid trickling from the cervix. If if it is observed that there is fluid from trickling from the cervix, then you know that this patient has PROM. You could also find that there is no fluid trickling. However, you can ask the patient to try to cough or try to increase the intra-abdominal pressure or bear down, and you would also observe fluid trickling if it is PROM. Sometimes, especially sometimes with the patients who are leaking, you might not see this fluid trickling or leaking, but you would see a pool of fluid in the posterior fornix. However, Sometimes there are other fluids that can be in this posterior fundus that aren't necessarily liquor. So you also, through your speculum, check for cervical dilatation if you can see the cervix is dilated, the position, see if the cervix is edematous or not, see if there are fetal parts, if you can see a cord. When you are doing this sterile speculum, you can use it as an opportunity to take your samples, which we'll talk about in further slides. It should be cautioned that one should avoid digital vaginal examination as much as possible, unless there is a reason to do it. If you are sure that this patient is actively in labor, or there's an abnormal CTG that was done prior, and then you want to assess if this patient can go through a vaginal delivery as soon as possible. That is when we try to do a digital vaginal examination. So we should try to avoid or minimize these examinations. We should know that preterm PROM has been shown to shorten the latency, which I spoke about earlier, and increase the risk of infection. So the more you're introducing your finger inside to assess for dilatation or to assess for fetal parts or with no prior indication, you are increasing the woman's chances of infections and also shortening the period in which this woman would stay before labor sets in. So there are some investigations we can also do to support our diagnosis, especially when the diagnosis is uncertain. So we have the nitrogen test. So this nitrogen, so generally the pH of the vagina is acidic, but the amniotic fluid is more alkaline. So when there's that mixture, the fluid becomes more alkaline in nature. So when you put a nitrogen paper on this fluid, you realize that it changes from yellow to deep blue. However, there are cases of false positives. So you should have that at the back of your mind. When there's presence of semen or blood or infections or even soap, that can change this same nitrogen paper to blue or black, but that isn't indicative of PROM. So even though it's sensitive, it has very low specificity. So you can also do the FEN test, where the fluid is put on a slide, allowed to dry, observe under the microscope to see if there's this arborization of the fluid. It also has its sensitivity and specificity issues. So it is not an absolute, it doesn't give an absolute diagnosis for PROM. We also have the litmus paper. It turns blue when it's in an alkaline medium. And we also have the amnio dye infusion. This is a test that is quite specific, but it's expensive and it is and it is invasive, where an indigo carmine is infiltrated into the amniotic fluid, so through amniocentesis, and then a pad or a tampon is placed in the vagina of the patient, and after about 30 to 60 minutes, you would see that the liquor coming from the pad or the tampon is stained with a blue color. Then you know that yes, this patient is actually leaking, or this patient is having PROM. Other investigations, which we call commercial investigations, because they are quite expensive, but they are also done out there. We don't do it in our setting routinely, but they can also be done, is the insulin-like growth factor binding protein 1, which is called the actin PROM. So all these proteins that you can see are proteins that are in the amniotic fluid. So when they are tested for, they either show positive or negative. And when they are positive, it's highly indicative of PROM. We also have the commonly known amnesia, which is the placenta alpha myoglobin 1 protein acid test. So the sample is usually taken, and this sample is put in a test tube with a solvent. Then the test strip is dipped into this test tube with a mixture of fluid. And then after about a minute, it's read, just like the way we do our RDT test. If it is one line, it shows that it is negative. And if it is 2 lines, it's positive. This is quite specific in about 97% of cases of PROM. We also have the amnioquick duo plus test, which is a combination of the insulin-like combination growth factor binding protein with alpha fetoprotein. We also test for these two proteins, and when they are present, it is positive and highly indicative of PROM. So other investigations that can be done include a full blood count. These are the routinely done investigations that are common in our setting. Full blood count, where we are interested in the WBC count because of certain complications that the mother can develop, which we'll talk about later on. We have a urine RE and then a urine CS as well. As we said, infections can be a predisposing factor. We have an endocervical and high vaginal swab for RE and CS. We also check for active phase reactants, such as the C-reactive protein, which is more beneficial to us as compared to the WBC count, because as we go on our management, we'll see that we would probably use steroids, and these steroids sometimes affect the levels of the WBC, but with the C-reactive protein, gives you a clear picture of the state of the mother. We have a CTG, which that can be done for the fetal well-being. An ultrasound scan. So the ultrasound scan, which plays a significant role in our diagnosis, where we are trying to measure the amniotic fluid index, and this amniotic fluid index we know is between 5 to 24. So above 25, we know is polyhydramnios. But in this sense, we are interested in reduced amniotic fluid index, which is below 5, which is oligohydramnios. Also, we can also use the maximum vertical pockets, which below 2, we also diagnose oligohydramnios. So in a patient who previously had normal amniotic fluid index or normal maximum vertical pockets, now comes and then you do an ultrasound and it is below the normal, you can suspect PROM, especially with the history and then the examination findings that you would have already found. So with these patients, it is very important that when we are attending to them, we have certain things at the back of our mind, other diagnoses that we should consider when we are seeing these patients, which include urinary incontinence, which is very common in our pregnant women because of the pressure of the uterus, we give them stress incontinence. Some of them are leaking and then they come with the same complaint, but upon examination, you realize that it is urinary incontinence instead of PROM. We also have excessive vaginal discharge or cervical mucus, even semen or vesical vaginal fistula. So let's talk about the management of PROM. We have general considerations. Before we go into the nitty-gritties of its management, we should always think about the risk of prematurity against the risk of chorioamnionitis of the mother and cord compression of the fetus when you are talking about the management of PROM. We also need to consider if the facility in which you are going to effect the delivery, do you have a neonatal intensive care services? Because the baby can be a preterm baby who will need these services. So generally, our management is in two. We have the expectant management and we have the active management. The expectant management aims at trying to prolong the pregnancy as long as possible, whilst the active management, we'll learn more about it as we proceed. So what are some of the criteria, or let me say indications for which patient can undergo conservative management? So these patients usually are preterm, so their gestational ages are less than 34 weeks. And before we can also think of managing these patients conservatively, we should also think about the fetal maternal condition of both the mother and the baby. If they are stable, then these patients are eligible to conservative form of management. So this is an overview of how we manage patients conservatively. So these patients have to be hospitalized. In our setting, we have to hospitalize them. Elsewhere, maybe abroad, you can think about home, which is home management, but it's not very advisable. So we do our hospitalization. Then we'll monitor our fetal maternal well-being, the maternal vitals, very important because when the complications start setting in, these are the things that will start indicating that yes, this is what is happening, and then we have to act differently and then change our management. So our maternal vitals, our temperature, our pulse rate, our respiratory rate, vital to our management. We continue with our full blood count, looking out for the WBC count, our C-reactive protein, and this can be done every 3 days, every 72 hourly. Every morning when we are doing our rounds or however often we do our rounds, we check for the general well-being of the patient, check for abdominal tenderness, which is very key because of the complications that can set in as well. We check and inspect the vulvar pad, check for any change in the smell of the liquor that is being produced, or whether or not there is even any liquor being produced. Again, we also do our fetal surveillance, our fetal kick count. We monitor our fetal heart rate 4 hourly. We do our non-stress CTG. We do our ultrasound scan to monitor our amniotic fluid levels. Then we have our antibiotic treatment. So usually put these patients on antibiotics. This is to prevent infections that can lead to complications such as chorioamnionitis. So one of the infections that we try to one of the let me say the organisms that we aim to prevent is the would be streptococcal bacteria. So we can employ the use of ampicillin or amoxicillin, erythromycin, azithromycin, or metronidazole. We also talk about steroid use. So we all know that before 34 weeks of gestation, usually our fetal lungs aren't very matured. So we employ the use of dexamethasone to help to mature the fetal lungs. There's also the use of magnesium sulfate, which helps as a neuroprotector for our babies, our preterm babies, so that it prevents cerebral palsy and others in the future. So there's this controversy about the use of tocolitis. So whilst other schools of thought think that they do not play any important role in the management, in the conservative management of patients, it's still being used to some extent. And this is just to allow for the steroids to act so that we can try to mature our fetal lungs before delivery. And also, if you're in a facility where you do not have neonatal intensive care services, you can give your tocolitis and allow for transport to a facility that do, so that delivery can occur. So, with all this treatment, our aim is to deliver at or after 34 weeks of gestation. Then we come to active management. So when do we do active management for these patients? When their gestational age is above 34 weeks. And then we stratify the risks to the mother and then the risks to the fetus. And if the risk to the mother outweighs the risk to the fetus, we go in for our active management. So in our active management, as usual, we have to give our prophylactic antibiotics. You have to inform your NICU services. Even though baby is 34 weeks, but baby is still not 10. Even though baby is 35 weeks, baby is still preterm. So you have to inform your NICU services that we'll be bringing a preterm baby or a baby whose mother had complications such as chorioamnionitis, which we'll talk about. And then this baby is predisposed to having neonatal sepsis and all other what do you call it, complications. So you have to inform your NICU and also assess this patient to decide the mode of delivery. You can have a patient who has come and then, even though the patient has PROM, the patient is already has a favorable cervix, fetal fetal well-being is optimum, and this patient can go through a vaginal delivery. These kind of patients, you allow them. But you have other patients who come and then they have maybe a cord presentation or cord prolapse, or they have presenting with some form of fetal parts, or you evaluate this patient and you realize that this patient cannot go through SVD, then these patients will be prepared for a cesarean section. So you have to um, examine your patient, you have to put everything together and see if there are no contraindications to vaginal delivery. You allow this woman to undergo vaginal delivery, but if there are, you perform a cesarean section for this patient. Then we talk about the issue of induction or augmentation of labor. So usually, some of these patients within 12 to 24 hours, especially the 10 patients, can go into spontaneous labor if you allow them. However, there are school of thought that believe that if these patients do not go into labor after a few hours, or you can actively manage these patients and then um, fasten the labor for these patients. So this induction or the induction can be done using oxytocin, misoprostol, or mechanical methods. It is proven that the use of oxytocin kind of prevents more infections to the mother, because when you are giving your misoprostol posterior phonics, you would have to go with your fingers and you might be introducing more bacteria into the cervical os, through the cervical os, which would provoke infections. Or when you are doing the mechanical methods such as the balloon induction, the catheter induction, where the same way you might introduce bacteria into the membranes and cause infections to the baby. So even though these are all methods of inducing labor, it is preferred to use oxytocin because there are um, lesser risk of causing an infection to the mother as compared to misoprostol and the mechanical methods. And we will augment our labor with oxytocin as well. So this is a summary of how we manage these patients. When they come at term, we induce labor, we give our antibiotics, and then if it's late term, late preterm, that's 34 to 36 weeks, as stated earlier, above 34 weeks, it's still the same management as the term pregnancy. And if they are preterm, that's from 28 to 33 weeks. We do our expectant management, try to buy time as much as possible, and give our max sulfates, articulators for transport or for buying time for lung maturation, our antibiotic cover as well. So let's talk briefly about the complications. There are a lot of complications, but these are the very common ones. So, with respect to the maternal complications, we talk about chorioamniotic, which is the most common complication. With chorioamniotic, we are worried about the maternal vitals. We have to pay attention to them, as I mentioned earlier. How is the heart rate? How is the temperature? How is the pulse rate? We examine our women. Is there abdominal tenderness? Is there an abnormal fetal heart rate? Um, how is the vaginal discharge? Is this offensive? We have how is the general well-being of the mother? We have to look out for these and try to um, expedite our delivery or try to go in for the best plan possible, which is the active management. Talk about abruption placenta, which is quite common, especially when there's that gush of fluid and then there's that rapid decompression of the uterus. It can cause the placenta to detach. And also it can also occur with those who have um, cord, cord presentation or cord prolapse. We also have an increase in cesarean births, as stated earlier. Women with chorioamnionitis or abruption, we might have to do a cesarean section for these women. Or women who are presenting with who the presentation is abnormal and then you have to expedite delivery, you have to do a cesarean section for them. Talk about the fetal complications. We talk about the cord accident, as we stated earlier. cord compressions because of the reduced amniotic fluid. That's the oligohydramnios, can cause cord compressions. We also have cord prolapse. You can have preterm labor. You can have prematurity and its complications, such as intraventricular hemorrhages. Um, you can have necrotizing enterocolitis occurring in them as well, respiratory distress syndrome occurring in them as well. You can have our oligohydramnios where you can have the presence of hypoplastic lungs, especially those preterm babies very far from viability, around 22 weeks, 19 weeks. They present with hypoplastic lungs. So have skeletal deformities because of the reduced amniotic fluid. It's very difficult for the babies to move and all of that. And then abnormal presentations and like fetal distress, intrauterine fetal death, and then neonatal sepsis. So to conclude, to conclude our presentation, I think clients' education during ANC is very critical in the recognition of PROM by the client. Because if the client doesn't even know that what she's going through can possibly put her and her baby at risk, she will sit home with um, whatever leaking or fluid that she's having coming from her vagina. So it's very key to identify those with risk factors, educate them appropriately, so that even the client themselves can know that okay, this is something that I have to rush to the hospital, and this is what I need to do, and all of that. Also, timely diagnosis and appropriate management of PROM with regard to fetal maternal state is key to reducing both maternal and neonatal morbidity and mortality associated with PROM. Also, clients should always be counseled on the risks and benefits involved in each management modality with a careful consideration of the patient preference in such regard. Let's not always disregard what the patient also wants with respect to their management. We have to try as much as possible to individualize our care with patients with PROM, because there are certain clients that are really going through infertility, issues of infertility, and they might come with these issues. We shouldn't just ignore what they also want, but make their decisions come into play in our management of these patients. There are also other, to add on, there are also other special groups of patients when it comes to the management of PROM, like our mothers with HIV and then patients with cervical cerclage. These kind of special patients, they have to be addressed in the presence of a specialist or a consultant, somebody, or an obstetrician gynecologist. These decisions are very crucial. So we need those inputs to be able to take those decisions. So if you're in a CHIPS zone or in a health center where you don't have a specialist and you have this special group of patients presenting with PROM, you've made your diagnosis, you think this patient has PROM, but the patient has a cerclage, or the patient is a retro patient, it's best to refer these patients to facilities that have the services of an obstetrician gynecologist to make the appropriate um, form of uh, management for these patients. So these are my references, and thank you very much.
Excellent. Thank you, Dr. Betty, for an excellent job done and quite concise, straight to the point, and quite educative for all of us. So we still have about some 20 minutes to have a discussion around it. We open the floor for questions, but just before the questions, Dr. Gildas, at any point you are available to make any inputs, kindly unmute yourself. I've made you a co-host as well. I want to acknowledge the presence of a group called Midwifery Exchange. They reached out to us a couple of weeks ago following our first webinar presentation. They are doing a great job with, I see the director of WA West on, Mama Cecilia. You guys are welcome. We are hoping that through these concerted efforts, we are able to improve upon the service delivery, especially regards to maternal and newborn care that we are leading. So we welcome you guys from the midwifery exchange group. And thanks for joining. And thank you to everyone who has joined us today. So the floor is open for questions. Just before then, Dr. Gildas, if you are available and you want to make any inputs, you could just unmute yourself and go ahead.
I think we'll take the questions normally.
All right, great. Okay, so if you have any question, just electronically put up your hand. I'll unmute you to talk. Any questions? Yeah, so maybe it looks like, Betty, your presentation was well understood because I don't see any hand up. There are a few questions in the chat box. Most of it is to acknowledge the great work that you have done. So I'll just read a couple of that out since we don't see any hands up. The first one is saying that, good day, please, how do I get the link and topic for each presentation on a weekly basis? Great. Phyllis, and to all those who probably don't know, we have several media that we put on these topics. On social media, you can like the Ghana Medical Health page on Facebook. And when you do, and on a weekly basis, you see the topic that we have. The same with our LinkedIn account, same name, and then you find the same topic being put up there. If you even forget to check for what topic it is, but you remember that same day, same time, 3 p.m. on a Friday like this, just click on the same link that we've been using for 2 years now. It's the same, it doesn't change. So whatever link you use to join today's meeting, you can use the same, make a date with us, 3 p.m. every Friday. Click on the same link, you are right at the very good spot that you want to learn. I also want to pass on the fact that I see Pearl asking about how do I get the recording of the slides and the recording of the meeting and the slides. So good. If you can just check on YouTube, there's our handle there as well, Ghana Medical Health. If you like and subscribe to our channel, you'll find this recording there on a weekly basis that you can listen to in the comfort of your home, wherever you are once there's network. You can even download it as well if there's issues with the network, and then be able to listen to it at any time. The good thing as well is that when you click on the comment section in that YouTube link, when you like our page, you'll find these slides there. So you can easily read the same thing that was presented in the form of the slides. So in whatever way, if you want the video, once you get onto the YouTube channel, which I'll post in the chat box now, you'll be able to listen to it just like we are having now. If you want to read the slides, when you like the same video on the same channel you subscribe to the same channel on the YouTube and click on the comment, you realize that whatever slides that were put today would be put there, the information will put there just as it is. So in whatever way, I don't think you miss out. I hope that addresses the questions about one, where to get to know what is being presented, which I said, any of our social media handles on Facebook, on LinkedIn, you can be able to find that. Or if you missed the presentation, you still want to go through it, or you were part of the presentation but forgot about something or did not understand something, you want to re-listen to it, just subscribe to our page. They are all there on the YouTube. I'm going to put it in the chat box right away. I hope that does justice to the two questions. Yeah, so Felicia also asks, says, very good presentation. Wanted to find out about magnesium sulfate being used as tocolytic, the dosage and how to use it. So team, anyone who wants to take that?
Boss, should I take that or you will? Dr. Gildas?
Yeah, I think you can go ahead.
Oh, go ahead.
Okay, so
You are well prepared.
so in the use of magnesium sulfate, just as I spoke earlier, it functions as a neuroprotector for the baby as well. So it's a very good choice if you want to use that as a tocolytic. Usually we give about 5 grams in 500 mils of IV fluid, and we allow it to run at a rate of 100 mils per hour. So yes, that's what we do.
Great.
Yeah, so to add to what she said, yeah, so I mean, you can give the max sulfate for neuroprotection, but then, as we say, are killing two birds with one stone. It also acts as a tocolytic. By using it specifically as a tocolytic, it's not. Some studies actually says that you should not give tocolytics in PROM, but others also think that you have to give it to prolong the latent phase so that the steroids can work. So there's no clear-cut dosage to it. So the amount you can give, as she said, here we give about 5 grams and 500 mils of fluid to run at 100 mils per hour. But some also give 5 grams at the start and then 2 grams per hour. But the danger with this is that these are foreign books, so you have to have the ability to measure the amount of magnesium sulfate in the blood, so that they don't suffer toxicity. So I think we should stick to the 5 grams in 100 ml. Some also say 4 grams start, but there's no fixed amount that you can use for neuroprotection. Thank you.
Great, thank you. So I still don't see any hand up. If you have any question, please electronically raise up your hand and I'll unmute you to talk.
All right, since they are not asking, let me just come in. So
Great.
let me start with the topic. Yes, I mean, we are now moving towards calling it pre-labor rupture of membranes, but you will not be wrong if you still maintain the premature rupture of membranes. They are used interchangeably. So with this condition, actually, it's about the management before and after 34 weeks. So after 34 weeks, as Dr. Osuglo said, you have to manage as a term pregnancy. You have to accelerate delivery. Because what this means is that you are trying to prevent infection. And the longer you tarry, the more likely you can get chorioamniotic, which can be fatal for both the baby and the mother. So how do you do that? Normally, if the PROM is more than 6 hours, it's advised that you start your antibiotics. And then you should not let it go beyond 24 hours. So you either augment, you have to assess the service. If it's favorable, you can augment with oxytocin. If it's not, you can give misoprostol. But it's advisable to give it sublingual, since you don't want to introduce pathogens into the cervix that might affect the baby. Now, below 34 weeks, consider that the fetal lungs are not yet mature. But, in other countries, they can check for fetal lung maturity around 32 to 33 weeks. But here, we don't really have those tests available. So below 34 weeks, it's advised that you give your dexamethasone. And then you give antibiotics. So you can read and find out that the antibiotics actually prolongs the latent phase. So this is where I was expecting that people ask, how does it do that? But the point is that once the membranes are ruptured, they're exposed to the vaginal flora, which has a lot of bacteria. So when you give your broad spectrum antibiotics, it prevents bacterial multiplication that can, if not, the bacteria can lead to inflammation that will trigger liver. So that's how you are able to prolong the latency phase with antibiotics. And we stuck with erythromycin because it's what we call the Oracle trial. That's the trial they did with amoxiclav and then erythromycin. And erythromycin was better because the amoxiclav can cause what we call neck in children, necrotizing enterocolitis of the newborn. So we give erythromycin and we give flagyl as well to cover anaerobes. But then you have to monitor both baby and mother. I think she did a good job by taking us through. You have to every morning or even every 4 hours check fetal heart, vitals, temperature, pulse. We all know the normal cutoffs, so you have to monitor them regularly. If not, if any of them change, you have to deliver because either the fetus or the mother is in danger. And don't go beyond 34 weeks. Some new studies have shown that you can send them to term, which is 37 weeks, but these are not being accepted yet. So and some have shown that there's not actually any benefit after the lungs are mature. You are just putting both mother and baby at risk. So even though those studies are there, they always come back in the textbooks to say that you should still pick the cutoff at 34 weeks because you are looking at fetal lung maturity and preventing both perinatal and maternal mortality. So I think this is all for now. We'll take more questions if there are any. Thank you.
Excellent, great. I don't see any hand up. Maybe a couple from the chat box, which are mostly just comments about how brilliant the presentation has been. So think there's one from Dorcas that is asking, can PROM cause amniotic fluid embolism? Can you respond to that? PROM causing amniotic fluid embolism.
I mean, we can never, there have not been evidence of that. What evidence has been, that one is artificial rupture of the membranes. Not, this one is more like or less spontaneous. So no, I am not going to affirm that. It's normal during ARM, that's artificial rupture, not. And I mean, amniotic fluid embolism can even occur in women who undergo normal labor. But PROM itself, I haven't come across that.
Great. iPhone says, please can the slide be repeated on the page again? I was late in joining so that I can screenshot them. So iPhone, I did pass a message that if you look in the chat box now, I've just put a link in there. That is a link to our YouTube page. If you could kindly click on that link and subscribe to that page, you'll find that within the next couple of days, this presentation will be put up there in video and in Word form so that you don't need to have to screenshot whilst trying to listen to. You listen and then later on you can have the whole video to watch it any way that you want as well, to also be able to have the slides if you want to. So just subscribe to the link I've put in there and you should be good to go. Thank you, iPhone. And usually it's good if you join in with your name so that then it's easy mentioning your name rather than the name of the device. Thank you. I think the last question in the chat there is from Dorcas, who says, I had preterm labor. I think hers is a comment. She had a preterm labor and benefited from the use of max sulfate. The dosage given to her was about 2 grams for neuroprotection, and it worked for her. And Rita is asking me to put in the link. I'll put it in just right away so that then you can subscribe to it and then you are able to listen to this teaching. Rita and all those who haven't seen the link, I've just put it in there again. Thank you. So that's it from the chat box. If anyone has any question, you could kindly electronically raise up your hand. I will unmute you to talk. We have about 7 minutes to the top of the hour. Okay, it doesn't look like there are any hands up, and just like I indicated, I guess we all did enjoy this presentation and understood it in depth. Again, a quick reminder that this presentation is available on the YouTube page in the next few days, and you can have access to it anytime you want to. The slides as well will be put in there so that then you can have access to that as well at any time you want to. So kindly subscribe to the page that I've put up, and then you have all of this. Again, with regards to the topics for each week's presentation, they will put up on our social media pages, both Facebook and LinkedIn. So you can like our page on Facebook as well as subscribe or like it on LinkedIn as well. You'll be able to find the topics on a weekly basis. However, even if you forget to look up in Facebook or LinkedIn, or you didn't get the time to do that, you do remember that on Friday at 3 p.m. there's a 1 hour teaching, which takes mostly less than an hour, and you get to learn a lot. So the link that you did use to join today's presentation, the link does not change. It's the same link that we'll be using for 2 years now. So on Friday, 5 p.m., just click on that link if you want to learn something about maternity and women health. You click on it 3 p.m., between 3 and 4 p.m., you are good to go. We use the same link as well for other topics in medicine and other disciplines of medicine. So that the date and the time to remember, the key time to remember again is 3 p.m. on Thursdays. So if your Thursdays and Fridays for an hour you would want to learn anything, you can mark it on your calendar, 3 p.m. Thursdays, 3 p.m. Fridays. So for the Thursday ones, we call those ones the community service agenda. They are mostly other non-maternity related topics. So this Thursday or next Thursday, we'll be having a presentation on medical ethics and the law. Will be led by a lawyer and a medical doctor who will be taking us through the law. So you make a date with us. If you like our Facebook page, if you like our LinkedIn, you'll be able to get the specific topics. But even if you forget to look up, but you remember that at 3 p.m. on Thursday, you can just click on the same link. Same link that we have shared for the maternity service agenda is the same one we use on Thursdays as well. So if you save that link, if you save that password, if you save that meeting ID, you can always use it, and it should be easy for everyone. If you forget and you are not able to join, but there's a topic that gets you interested and it's already been done, kindly just subscribe to the YouTube link or YouTube channel, and then you are able to listen to it. I hope this brings a lot of clarity on the questions in the chat box, because someone just put up there just a second ago that, please, can I get the slides? So again, for emphasis, Victor's Wharton, the emphasis is that there's a link I've put up in the chat box, which I'm just going to put up again. Just click on it. Yes, it's up now. Just click on that link and like that page. You have both the slides and you have the video. Thank you, Victors. There's a question from Mohammed. I think should be the last one since it's just about 3 minutes. It says, please, can a woman who delivered had CS, please, can a woman who already had CS for her first delivery can deliver normal on a second delivery? Is that possible? Yeah, I think she's talking about VBAC. Dr. Gildas, Dr. Betty, your response to it.
Betty, take it up.
Boss, I didn't get a question.
Can a woman who has had a previous cesarean section deliver vaginally subsequently?
Oh, yes, she can deliver vaginally subsequently, but she needs to satisfy the criteria for a vaginal delivery. And if she meets all the right, if she ticks all the right boxes, then she can be allowed to undergo vaginal delivery. In our setting, we do not allow women with with a fetal weight of above 3.5 kilograms to undergo vaginal delivery. So if she does a scan and the scan is estimating the fetal weight above 3.5, she doesn't meet the criteria to undergo vaginal delivery after a cesarean section. If the interpregnancy interval too is very short, well, some books say 12 months, others 18, and others even say 6 months. So if the pregnancy interval is short, this woman will not be allowed to undergo a vaginal delivery. And also if she has a recurring indication for her previous cesarean section, let's be it breech presentation, and then this pregnancy too is another breech presentation, she'll probably not be allowed, she'll not be allowed to have a vaginal delivery. Or she has a pelvis that isn't adequate to undergo a vaginal delivery, she will not be allowed to undergo a vaginal delivery. Of the child, this is what I can say. Boss, you can add the rest.
Is there a rest to add? Anyway, I think you've said it all mostly. But whatever the cases, this is a type of delivery that the specialist must make the input in. As she said, there are a lot of factors and controversy surrounding it. But women do deliver after cesarean section. Most of the time it happens. And about 3/4 of those who go into labor after a CS will end up delivering. But such delivery must be monitored and must take place in a place where there's a specialist and there are theater services, because complications can occur, which includes uterine rupture. So that when there is close monitoring and these complications occur, you can quickly go to theater and save both mother and baby. So yes, VBAC, that's why it's called anyway. Vaginal birth after cesarean section. is something that is actually, I mean, I think we should present on it one of these days. But you need specialist input and you need to deliver in a place with theater services. Thank you.
Great. Thank you. And thank you all for the question. Just a word of comment by way of, please don't feel shy to electronically put up your hand and then talk. It's interactive. And so it makes the discussions lively. We are all learning and there's no wrong question. You are born to clarify what you want to, rather than risking it up on the patient. So kindly feel free to usually electronically put up your hand. We'll be glad to have and to hear your voice. So I want to say thank you so much for joining us for today, and a special thank you to the maternity team from the Upper West Regional Hospital, Dr. Betty and Dr. Gildas, for leading us today with preterm rupture of membranes, or what is also called the Prelabour Rupture of membranes. We've learned a lot. Until yesterday, I didn't even know there was a new technology like that. So everybody's on the learning curve, and usually when things like this come up, especially if you are available, kindly make time to join us. Because peculiarly where we are located, it's quite difficult to have access to updated guidelines, because mostly it's either one prescriber or a few prescribers in a district. But this then creates sort of a mentee-mentorship relationship, also creates some form of a referral chain, such that if you are in Hamilton, you can easily pick up a phone and call Gildas or Dr. Betty, or you are able to talk to someone before you send on the patient, because sometimes it may just be easy passing a life-saving intervention that you may do. So kindly make a date with us anytime you are available. We are happy to host you, and we are happy to have you on this platform. Thank you so much for joining us today. Excellent job, Dr. Betty. Thank you, Dr. Gildas, for your inputs. And thank you to all of you who have joined us today. Have a wonderful Friday until we meet on Thursday and Friday next week. God bless all of us, and bye-bye.